Hi, everybody. My name is Dr. Katrina Lindsay. I'm here today to talk to you about mental health and resilience. We're going to wait a minute or two just to let people jump on. Okay, great. I see people popping on here. I'm excited about today. It's perfect timing for this conversation. Excellent. We'll let people load here. This is such a neat thing that Facebook can do. This is my first time ever using it. So if I get glitchy, I'm blaming it on that. Great. We'll give it another minute just to let people load up here. Awesome. I see some familiar faces and names. That's exciting. So for those of you using the comment box, today we're really going to have a nice dialogue and a conversation. So I want you to be able to use that at any time if you have a question that pops in. So we're going to go ahead and get started. My name is Dr. Katrina Lindsay. I am the Tick and Tourette psychologist at the Tick and Tourette Service Center at Akron Children's Hospital, which is recently designated as a Center for Excellence. So I am here today to talk to you about mental health and resilience. So I got a couple really awesome questions before the live event, so I'm going to make sure that I answer those. But again, feel free to put your questions and comments in the box. So just a little bit about my background. I am a clinical psychologist by licensure, but my background really is in pediatric school psychology. So I went to Lehigh University outside Philadelphia to study school psychology. I did my residency, or also called an internship, at Rutgers University. And then I did my fellowship right here in Akron, Ohio at Akron Children's Hospital. So like I said, right now I'm the director of the Tick and Tourette service, and I also run something called the School Success Clinic, and that's for kids, youth, and young adults that are having difficulty in school. So they'll come see us for a day, and we partner with that school so that they can have an awesome school year. So today what we're going to do, I'm going to talk about the things I can do, and then I'm also going to talk about the things that I can't do. So the things that I can do today, I'm going to practice something called unconditional positive regard. And what that means is there is no question that you can ask that's going to make me feel different about you. I already know that these are the most awesome kids, youth, and young adults and adults in the world. And so there's nothing that you can say or ask that's going to change my opinion about you guys. I'm also going to practice being an open book. So if there's questions that you have about mental health or tics or resilience, totally. But if there's also questions you have about what it's like to be a psychologist, or what was my most challenging case, or what is something I'm always going to remember, what's my funniest story, I'm happy to share that information with you guys too. So what I can't do, what I cannot do today is I can't help if you're having a psychological emergency. So if you feel like you're having a mental health or psychological crisis, or something that we're talking about today is triggering for you personally, what I would highly recommend would be to end the live session and call 1-800-273-8255. That's the suicide prevention hotline, right? If you were unable to access support immediately through that, I would hang up the live event and call 911. Another thing I probably cannot do today is give a lot of information about medication and medication management. This is where it gets a little bit hard with mental health treatment because there's psychologists, there's psychiatrists, there's mental health therapists, there's a lot of us in the biz. I understand that a lot of people have questions about medication. And so what I'm going to do today is if you have a question about medication, I'm going to show you and teach you the ways to be a very informed patient and how to take data to partner with your medical provider to make the best choices possible for medication. All right, so let's start. I'm going to first start by just answering some of my own questions, and these are going to be kind of the take homes for today. And then I'm going to jump into the questions that I got previously before the live, and then I'm looking right at the comment box. So the first thing I wanted to talk about today was something called resilience, right? Resilience has been around forever. I feel like anytime we have a conversation about mental health, resilience quickly follows it. The concept of resilience actually comes from agriculture. So the concept of resilience was first started when farmers were trying to figure out what made some seeds grow and flourish and what made some seeds die, right? And what they ended up finding in a lot of early resilience studies is it wasn't the seed itself, it was the stuff that was going on around the seed that allowed it to be successful. So then several years ago, a researcher, her name is Ann Maston, she took that concept of resilience in seeds and she applied it to resilience in children when we think about mental health. And so she has probably one of the best, I'd say, scientific articles out there. So if you wanted to dip your toe into journals and scientific research, this is a great paper she wrote. It's something called Ordinary Magic. And that paper by Ann Maston really concluded that it isn't really what's going on within the child that causes that child to be resilient. It's the things that goes on around the child that causes them to be resilient. And that's what I want to talk about today, right? You guys participating in a live event in the middle of summer, that's resilience, right? Because you guys are establishing a community with each other, right? You seeking out support in community events in your state or partnering with the Tourette Association, that's resilience because you're building a community around your diagnosis. So that's the most important part of today. Resilience isn't about within, resilience is about around. The other thing I wanted to talk about today, because this is probably the most common question that I get, is, hey, doc, kids with tics, do they also have other diagnoses? I actually saw that come up in the comment box. And for kids with tics and adults with tics, the most common diagnoses are ADHD, OCD, anxiety, and depression. Okay? I would say of the hundreds of children and young adults and adults that I've treated, probably on one hand, I can think of children that only had tics. Most of the time, it's tics plus one of those three, or maybe even tics plus all of those three. Okay. If I have a resident that's shadowing me and I want to show off, and that maybe that patient is seeing me in the school success clinic, and maybe that patient, has some ADHD symptoms or experiencing anxiety, I can kind of just put it out there and say, this is kind of an out there question, but do they ever do things over and over again that they can't help? And that parent might say, oh yeah, I've noticed this eye blinking, I've noticed this throat clearing. That's wild you asked me that. But that's because we know those diagnoses are so comorbid, which means they're so connected and clustered together that it's very common to have one plus the others. Okay. This is a super important message because if you're experiencing ADHD, OCD, anxiety, and depression, and are part of the TS community, you are not alone because that's a very common experience for a lot of patients to have. Okay. When a patient comes to see me in the Tic and Tourette service, the first question that I might ask is, what's driving the bus right now, right? So maybe they do have tics, but anxiety is driving the bus. And so I know that they might not be successful in something like CBID if we don't get that anxiety in control, right? Or maybe they are struggling with focus. So maybe we're going to look at that pharmacological intervention or look at that behavioral support prior to beginning CBID to allow them to be very successful. Okay. Anxiety and depression are both related to something called the serotonin system. And so those two are very connected to each other. Sometimes when you think about a patient that might have anxiety and think about a patient that might have depression, you might think of two very different patients, but that's actually very common for those two diagnoses to go together. So again, that's another very important message today, that if you're experiencing one or all of the diagnoses that I described, you are not alone, because that's what we know in TS medicine. The other very common question I get is, okay, doc, I'm experiencing these diagnoses. What is the best treatment? And so I'm going to go back to the research again and give you another study to pull up for those of you that are interested in looking at scientific journals. And this one's called the ADHD Cohort study. So the ADHD Cohort study actually followed a group of kids with ADHD for many, many years. And they were asking a lot of those big questions. So things like, is ADHD, is it genetic or is it environmental? What treatment works the best? How can we support these kids as they age into adults. What does intervention and support look like? So it's a really neat study because it follows the same group for that many years. And what this study and others like it have found is often the best approach for mental health is a combined approach. So maybe we are doing medication and intervention, okay? The second most successful intervention is when we do behavior intervention alone, okay? And often the third most successful would be if we did medication alone. So again, a combined effect of medication and treatment, that's number one. Treatment alone, that's number two. Medication alone, that's number three. That's what we know, okay? A lot of times, really good mental health providers are very used to talking to medical doctors. So when I am working with a patient that maybe has depression, I am working very closely with that medical prescribing provider to say, oh, I noticed a change in these symptoms. Or they described a side effect of, mouth dryness or getting tired at night. Do you think it could be related to this new medication that you guys are trying? That's a strategy that a good therapist would use because, again, we're trying to build resiliency. We're trying to kind of build a tribe around that patient to allow them to be successful. Okay. So I'm going to go to the questions that were given to me prior to the live, and then I've seen a lot of really awesome questions kind of coming in the comment box. So for those of you that are just joining, my name is Dr. Lindsay, and today we're talking about mental health and resilience in the TS community. So again, put those comments or questions in the box, and I'll try my best to get to them. So the first question I got was from Hada, and she asked, how does somebody deal with anxiety at school, and how should they face challenges in a new environment? Okay, anxiety is so common in the school environment. Okay, so that's one of the things I wanted to say. I think even as I have school in the rearview mirror, I still wake up and have anxiety dreams about projects that I forgot or tests I didn't study for. So even in me, it's still in there. So the strategies that I often teach my patients, I have two that I put right in their toolbox. So things that they can use right in the classroom when they're feeling anxiety. And then I'm going to teach you some more as parents. So one concept I teach all of my patients is something called mindfulness, right? Mindfulness, like resilience and mental health, is a pretty big buzzword. But when I'm introducing this concept of mindfulness to patients, I just talk about the feeling of being present. So not focusing on the future, not thinking about the past, staying right in this moment, okay? If I'm about to sit for a math test and math is very challenging for me and I start to experience anxiety symptoms, I would guess that my brain is either thinking about the future, oh man, what happens if I fail this test? Am I going to fail this year? Or the past. I remember that last math test I took and the grade that I got on it. It's going to go just like that again. So practicing keeping my mind right in the classroom and not thinking about the future or the past. Oftentimes when I'm teaching a patient the strategy for the first time, we might check into our five senses. So if I'm sitting in a classroom, what I might do is I might feel the pencil in my hand, right? I might hear the clock on the wall. I might smell the smell of chalk on the chalkboard and see the backs of the heads of the students, right? I'm bringing my body kind of back into itself and keeping my mind in class, okay? That is a very challenging strategy. And often when patients are starting mindfulness for the first time, we might practice being mindful for a minute, okay? Especially if there's external distractors, right? So if I'm an easily distracted kiddo, or if I'm an adolescent with anxiety or adult with depression, it's going to be hard to kind of stay in my brain and stay in the moment. So we might practice 1-2 minutes and then grow that skill over the summer so we can really start using it in the classroom when school starts. That's one, okay? The second strategy that I teach patients is something called diaphragmatic breathing, or belly breathing, or performance breathing. And I'm not going to turn the screen on to see you guys, but this is the best way to learn it. So I'll have my patients pretend that there's a teeny tiny little baby flower in one hand and a little itty bitty candle in another hand. And then all we do is we practice smelling the flower for 3 seconds, holding our breath for 2 seconds, and blowing the candle out for 3 seconds. So I don't care, I'll embarrass myself. This is kind of what it would look like. Okay. Then, once we get really good at this, we can put our fists down and just kind of imagine that in our head. When we experience anxiety, often the first thing that goes is our breathing. So our breathing and our diaphragm and our lungs start communicating to the rest of the body that there's danger about, that it's time to fight, flight, or freeze. So the easiest thing we can do is to come back into our breathing, okay? 2 really great strategies that you guys can take away from today. So say you're practicing those strategies over the summer and school time starts and your child's still experiencing stress. What I would recommend is having a point person in the school. Okay. This is different than me saying, like, hey, go talk to the guidance counselor. I'm not saying that. What I'm saying is, I want somebody in the school that knows your child or knows you and your story, right? And I don't really care who it is. Like, it could be the school psychologist, it could be the favorite lady in the cafeteria, the janitor, an old teacher. I want somebody that has a dog in the fight for you. And this could be somebody that you could go and check in with in the morning or check in with at the end of the day that kind of knows what you're going through living with a chronic diagnosis. Okay. What's good about that is if you have a point person that knows what you're going through, that again creates resilience because we're creating a support system around you or around your child in order to be successful. Okay. The last piece, and I would be remiss not to bring this up as a school psychologist myself, is that if your child or you are continuing to struggle, remember that there are supports in place that are backed by special education law. So consider something that's called a Section 504 or an IEP, okay? A Section 504 is a health plan. So Section 504 would provide you or your child accommodations, like maybe access to the guidance counselor, maybe the ability to walk out of the classroom and take a breather and come back in order to be successful. A 504 plan is a health plan that wouldn't be different for a kid that has asthma or diabetes, right? Because having a mental health condition or having TS, that's a medical condition. And so you also fall under that law, okay? A lot of times people get confused between a 504 and an IEP. An IEP stands for an individualized education plan. So an individualized education plan would be that maybe perhaps you have depression, but also you have a learning disorder in reading, right? So an IEP would provide accommodations both for your reading and depression and intervention. So maybe on top of the support that you're getting for depression, you're also getting to work with a specialist using an intervention to help with that reading skill. That's the difference between the two. And the last part about that question I thought was really important is how to face challenges in a new environment. The best way to face challenges in a new environment is to make that environment as familiar as possible, right? So doing small things like walking around the new building if it's new construction, or getting the opportunity to meet teachers, or practicing using my locker combination code before the day, that helps my body get out of fight, flight, or freeze mode and increase familiarity with a new environment. For all of us, when we experience a new environment where one day it was different and the next day it was completely different from anything I was ready or prepared for, we're all going to have symptoms of anxiety. And so increasing familiarity, partnering with those stakeholders, and establishing resilience again by making that new environment familiar, that's how you build success. The next question I had was from Dave, and he said, how do you help an adult immobilized by self-medication such as marijuana? Again, this is a very important conversation that's happening in the TS community. I would say that the science and use of THC in TS and in mental health, that's kind of a new space and a new science. So I would, again, rely very heavily on medical providers and the directives of your state. So some states you are able to use marijuana, right? And some states you are not, right? And some states are able to use it medically and some are not. In my state, it really varies by hospital. And so even though my institution may not prescribe, there's also really good providers that might do a consultation. So that might be where I would start. So just because your state does not have marijuana laws, that does not mean that there might be someone that could provide expert consultation about the utilization of marijuana for mental health or TS symptoms, okay? I think it's really important when we think about the use of recreational substances, the difference between wanting to feel better versus wanting to feel normal, okay? this would be the point for this adult that's in your life. I would recommend probably connecting with a mental health therapist or a psychologist, right? That provider could really get into the why and what is the use of this marijuana, and like make some really good behavioral goals working towards getting a decrease in that, and identifying what are the core underlying issues that's making this person feel immobilized, right? When I hear the word immobilized, when I hear that word, again, I'm thinking flight or freeze. I'm thinking about things like anxiety and depression. Anxiety and depression immobilize us. So I would want a really solid provider that would be able to work on those anxiety and depression symptoms. Okay. The next question I had was from Laura. She says that she has identical twins. One has gestures and movements, and one has both noise and movements. And she wants to know how to deal with anxiety and best medications at present. She described 2 medications that her children are on, and she also wants to know how to deal with noise. So I can take a tackle at this. Again, I would rely on that ADHD cohort study and make a case that probably behavioral treatment and medical treatment at the same time would probably be a really good fit for your twins. Okay. With medications, again, psychiatry is a newer science in the field of medicine, and psychology. We're kind of new at the lunch table. And so it's often a very challenging and stressful experience for parents when they're starting to kind of tiptoe into mental health medication. I say this a lot to my families, that sometimes mental health medication is like playing darts in the dark, right? It's like we shut all the lights off, throw darts at the dartboard and turn the lights on and see what darts stuck, right? That is a terrifying experience for a parent. I absolutely understand that. And so that's why when you work with a psychiatrist or work with a medical prescriber, they say things like low and slow. So often medical providers are going to start at the lowest dosage and they're going to slowly titrate up, right? What happens is often you don't really see an effect until we find that ideal level of medication and that perfect type of medication. So it can be a course of months, which can be really stressful for families because often psychiatrists are booked for months. So it's like you spend all of this time to get in front of this medical provider, and then we start a medication and it's kind of low and slow. That is a very common experience. Okay. If I were you, Laura, what I would do is I would go back to the medical provider that's prescribing this medication and I would ask about his or her comfort level. So neurologists and primary care providers can have very differing levels of comfort when it goes to psychiatry medication, right? Some of them might say, I'm really comfortable with ADHD medication, but if a child's experiencing anxiety or depression, I want my psychiatry colleague to look at them. So that would be a really good question I would ask as a parent. Kind of where is your comfort level with this type of medication? Is there someone that you could refer me to? In my institution at Akron Children's Hospital, we have psychiatry right in the hospital. And what makes that very nice is that if one of my patients is seeing a psychiatrist, that patient can very easily communicate to their neurologist and talk back and forth about medications and changes. So that's a really nice model that's starting to really break ground in a lot of hospitals. Another great thing you can do for your medical providers is to take really great data. So that's what I would recommend for you, Laura, is kind of put together a spreadsheet and look at changes in behavior in your twins. So are you noticing that they seem more anxious in the morning or more anxious at night, or their tics are louder and more rapid during the school year? That would be really good information to kind of quantify what you're seeing and sharing that with the provider. That's where I would start. And then with the noise piece, I think every parent is experiencing increases in noise as we kind of lock down here at COVID and summer starts. One of the strategies that I actually used as a camp counselor that now I also use in my family is something called H hour. And so H hour means that we take an hour and you have to stay horizontal. You can do anything you want in that hour, but that is an hour for the house to kind of quiet down, stay horizontal, and find something to do, right? That's a very easy sneak around to get kids to nap, right? But if your kids are a little bit older and nap is treated like a bad word in your house, calling it H hour and just letting to have an hour of silence in the family system, that's a really good strategy. Remember that tics are connected to boredom and stress. And remember that stress is a dual definition. So stress can be negative stress, like a math test, but stress can also be excitement. So if your kids are hooked up to games or having really exciting soccer practices, that kind of stuff might make some of our tics a little bit louder because we're getting excited and the body doesn't know the difference between excitement and stress. Okay, so those were all the questions that came in ahead, and I saw a lot of questions coming up in the live comment feed. So what I'm going to do is I'm going to scroll all the way up to the top and see how many I can get through. And then if we don't get to your question, if this is something that you want information on, I'm going to work with the TA to see if I can provide you some answers if we don't get to it today. Okay, great. Got a lot of good hellos. Okay. Okay, so this question is from Carrie. She wrote, her son is 7 years old and does not realize he has Tourette's just yet, although he knows he moves and says things when he doesn't want to at times. How and when do you suggest sitting down and explaining to him that he has Tourette's? Any tips for that conversation, please? Great question, Carrie. So a lot of parents have this question, and unfortunately there isn't a perfect time because every child is different, right? And every child developmentally might be at a very different story in regards to their advocacy and understanding with TS. I have patients that I work with in college that aren't really ready to identify as having with TS or telling other people, right? And advocacy and identity is kind of its own chapter, right? When I am working with a child and maybe a parent tasks me to support them in telling their child about TS, a lot of times I'll rely pretty heavily on that amazing iceberg that the TA put out. Because tics, remember, tics are the tip of the iceberg. And so a lot of children grasp the idea of TS when we look at what's kind of under the water, right? So when we think about things like executive functioning or handwriting difficulties or depression, they might have a better understanding of what's under the water. So if we spend time there and then go up to the tics, that's very helpful. I see a lot of really amazing familiar names on this chat box. And for those of you that have worked with me, I take a strengths-based approach when I tell a child about their TS. And so this chokes me up even talking about it. My patients that are on here know this is me. But people with TS have incredible superpowers, right? They're smart, they're sensitive, they're perceptive. Most of the time, I see those superpowers before I ever see a child's tic, right? And I'm guessing, Carrie, your son is just like that. And so I sometimes will put it in a superpowers framework, like all these amazing things that you are because of your brain, and tics are kind of a side effect of that too, right? When I talk to a child, even as young as 7, about TS, I focus on the chronic piece, right? I think that's very important. And that's just a personal choice that I have made as a provider, that I think it's important that children understand that tics are chronic, right? That there is no perfect medication and there is no treatment. And a lot of really good CBIT providers are also working on living with a chronic diagnosis. And what chronic means is sometimes the tics are really bad. Sometimes it's like they don't even exist, but they're always part of my story because those superpowers are part of my story. Okay. Sometimes the analogy I will use is a bus. So it's almost like on a school bus of life, TS is on your bus, right? And this bus is different because this bus has no doors. So what's on your bus stays on your bus. And sometimes TS might be in the front of your bus, telling you when to turn left and telling you when to turn right. And sometimes TS is in the back of the bus silent and it feels like it isn't even there, but it always kind of stays part of your story. So those are the strategies that I have used, Carrie. If you're working with a provider and you want to partner with that provider to tell your son, that would be totally appropriate. Okay, I'm scrolling down here. Okay, Rachel writes, my 14-year-old son is mean, snappy, and grumpy after he finally gets off his computer from playing Minecraft, after yelling many times to do so. Can this be real? Of course he thinks I'm wrong. He has TS, OCD, anxiety, and ADHD. Rachel, I feel like you set me up for this perfect answer, right? Remember, this goes right back to that comment about stress and excitement, right? A lot of my patients play Minecraft. I feel like I have an additional PhD in Minecraft from talking about it all day, every day, right? If we are playing something that makes us feel excited and stressed, And then we get told to get off of that. So our dopamine system is primed. We're having the time of our life on this game. It is so common to then kind of act and get in a stress response, a fight, flight, or freeze response when we're told to get off that game. Okay. So first thing I want to do is support that that is a very common experience and that you are very much not alone with grumpy Minecraft players. Okay. What I would do is I might set that expectation before he ever gets on Minecraft, right? So maybe we put an expectation around, and I understand it's COVID, and I understand that for a lot of teenagers, this is their primary social outlet. So parents, listen to me, don't let your jaw drop too far on the floor. I would put, a fair expectation in there. Maybe we say an hour and a half of Minecraft a day. Maybe we set that up, right? And if he is able to get off Minecraft without you nagging or telling him to do so, maybe put a reward in there. So maybe he plays for an hour and a half every day. If that hour and a half hits and he is off and downstairs, then at that point, he maybe earns an additional half an hour, right? So that puts you out of the role of grand punisher, right? And we are using positive behavioral intervention to support him making the right choice instead of punishing him for making the wrong choice, right? It's so hard with teens, right? And a lot of my patients, what I will say is if you want to tick a teen off in like 5 seconds, just tell them how to feel, right? So all of this really fits into what we know. And again, it seems like he has TS, OCD, anxiety, and ADHD. So he hits all of those very common pieces. And so I'm guessing what you're seeing is like a combination of all of those, right? We're having a little bit of OCD, with our rigidity. We're feeling anxious and stressed. We're hyper focused on the game that we're playing. I hear a lot of those pieces at play. So again, rely on that positive behavior intervention to support him when he makes the right choice instead of punishing him when he makes the wrong choice. And good luck with that. Okay. And then, oh yes, David Harris, he wrote some really nice comments too. It sounds like he's supporting you and understanding. Yes, right? A lot of kids and teens and young adults and adults are playing a lot of video games right now, right? And I understand that it is an escape. We're in a very stressful time in our world and in our country. And so I think that's common that kids are having a hard time understanding when to cut it off, when that's kind of their primary escape. Okay, so Mary Jo, let me expand this. She writes, can you address strategies for obsessive compulsive thoughts? My 14-year-old son gets things stuck in his mind that he cannot stop thinking about. For example, a new object that he wants. And this creates stress or anxiety because he gets stuck in thinking that thing and can't move on, enjoying the moment or doing what needs to be done at the time. Perfect question. And so I would also say that this has to do with OCD, but it also has to do with this concept called executive functioning. And executive functioning lives right up in the frontal lobe. And the thing that it's in charge of is something called shift. And shift means we can shift from one topic to another, or like the comment above, we can shift from a preferable activity to a less preferable activity. So what makes something OCD is that we also have a compulsive behavior, right? So it sounds like he's maybe having some obsessive thoughts or some restrictive thoughts. The compulsive would be the behavioral component of it. So that would be like if he can't stop asking you about it, or like he's ruminating on it and physically doing something while he's talking about it, right? Sometimes what I will do with a patient that has OCD type thoughts is we're going to lean into that a little bit. And this sounds a little bit counterintuitive, but we might practice getting to sit in our thought for 15 minutes, but then at that 16th minute, we're done. Okay. So what I mean by that, if there's like an object that he really wants, so there's like an X-Men character that he really wants, maybe what you could do, Mary Jo, is say, okay, I'm going to let you talk about that X-Men figure for 15 minutes, ask me questions about it, look it up on Amazon, see how much money you're going to have to save for it. But then on the 16th minute, if you have that thought sneak in your head about that X-Men character, I want to practice doing what's called thought challenges or pushing that thought away. We're seeing that thought in our head, but we're not becoming that thought. Okay. This is a really good strategy to start working on what's called thought challenges or working on those restrictive thoughts that kind of grow in our head. Right. Patients that have OCD, a lot of times they do a treatment that's called CBT. So that sounds very similar to CBIT, but it's a little bit different, right? CBT stands for Cognitive Behavioral Intervention, okay? Lots of my patients that might be on this comment box know that I talk about CBT, but the focus of CBT is on the behavior and the thoughts. So we know that feelings, that seems to be where psychology is feelings, right? But good psychologists and good therapists often work on thoughts and thought challenges. We stay in the emotion. We know that emotions are here to stay, and we're not going to waste our energy and currency on pushing away emotions. We're going to work on thought challenges and behavior because those two pieces are easier. And the theory is if we work on behavior and thoughts, emotions will follow, even if it's a little bit later. So again, that would be a strategy that I would use while you look for an excellent CBT therapist. Okay, scrolling down to my next comments here. Nikki writes, my son was diagnosed almost 2 years ago and is 5, and he struggles with rage. Again, such a common experience, and I really feel like one that's often not talked about enough in the TS community, right? Kids and adults with Tourette's have something called rage attacks, right? And rage attacks, again, have to do with executive functioning, right? It's almost like just this explosive experience of anger or hopelessness or frustration, and it can be intense and it can be violent and it can be self-destructive, right? And then it's suddenly like the clouds clear away, right? And so knowing that that's part of this diagnosis, I think is half the battle, right? Again, I would go back to CBT. So while we cannot control the emotion, so maybe your son is extremely frustrated with losing Fortnite. Well, he's 5, so maybe not Fortnite. Toppling over his Lego tower. Maybe he's extremely frustrated. He's allowed to have those feelings. The choices are in his behavior. So giving him safe options to express his frustration while he kind of gets through that rage attack, that would probably be the best strategy for him given his age, right? Maybe he has a punching pillow. Maybe he gets to yell into a shoebox. Maybe he gets to rip up a piece of paper in the garbage. He's getting it out. He's doing a behavior strategy. We're not pushing away the emotion because he's allowed to feel that way. And then when he's older, we would start working on thoughts. Okay. There's actually a really good book. It's by Russ Green, and it's called The Explosive Child. And so obviously that title's a little triggering, I think, The Explosive Child, but it's a great book. It's about rage attacks, and it's about something called collaborative problem solving. So it's about meeting children, youth, and young adults where they're at when they're experiencing really high level emotion. So that might be some good reading for you to start, Nikki. Oh, David also had a really good comment about reading a mindfulness workbook for OCD by John Hirschfield. Good recommendation. Okay. Yes. And it's horizontal hour, right? So you might have to start small. It might have to be horizontal 30 minutes and work up to an hour. But this is my secret strategy because usually they end up falling asleep. But it's just a good way to quiet down the house and pull the plugs and just make it kind of part of the daily family culture. Okay. Sam brought a great point up. We had our kids take hot showers and massage their legs. Both my boys had that. Okay, great. So again, great strategies. You're using those 5 senses. Okay. Christine writes, I have 3 sons, all with TS. They struggled all the way through school and are now not willing to go to college because of bad high school years. Any thoughts for motivation with Tourette's? Oh my goodness. So my thoughts are with you. I think that so much of what we know about TS and under the iceberg, that's newer knowledge, right? And so I think there is generations of youth and young adults and adults that didn't have this incredible community, right? And so what I would recommend, Christine, is maybe connecting to a CBIT therapist or a CBIT psychologist. The reason I say that is because they would have a really good understanding of what it means to live with TS. And, maybe they work on some tick strategies, but, more focused on the chronic nature of this diagnosis, emphasizing the superpowers and talking about how not only you can live with this diagnosis, but you can thrive with it. And you can really capitalize on those superpowers to be very successful adults, whether you go to college or not. So if there are some additional resources I can provide you offline, I'm going to make sure to do that because I want your awesome sons to just capitalize on those superpowers that I know they have. Okay, scrolling through. Okay, so Charlie writes that he is from Ecuador. He has TS and symptoms that arose since 10 years old. In his case, there are 3 ways that he learned to control his tics. He's a musician. Every time he plays music, they disappear a lot. Every time he works out his concentration on intellectual activity, and CBD reduces tics considerably. What would you say about that? I would give thumbs up to that, Charlie. So especially I can talk about those first 2. So science backs you up, right? So if you are playing your instrument or if you are concentrating and focused, you are using a different part of your brain than where the tics live, right? So tics are in the motor cortex. Concentration and focus when playing a musical instrument are in the frontal lobe. I use this example a lot for younger kids when we start talking about the difference between the frontal lobe, which is in charge of focus, concentration, executive functioning, and the motor cortex, which is in charge of automatic movement. So science backs up the strategies that you're using, Charlie. And so this is often a really special moment when I'm working with a patient with TS that they didn't realize that what they are doing has scientific backing when they don't see tics. Okay? There's some really incredible YouTube videos about a pretty prolific musician that had TS, that when they play their instrument, it's like those tics don't exist, right? So it's a very powerful video to show patients. And the reason that that's happening is because they're using their frontal lobe. So science backs you. And again, like I said, with CBT and tics, the science is new. So the jury's out on that, but I'm happy that that strategy works for you. How about that? Rhonda writes, how do I talk to siblings of a child with TS, ADHD, anxiety, rage, etc.? They're often targets of anger and hyperexcitement. Okay. So in my practice, sometimes I will meet with the sibling. So sometimes, again, I'm going to use that strengths-based superpower approach and maybe start with highlighting the things that are awesome about their brother or sister. So what are things that you love about Charlie? And then I'll have them list it out. And a lot of times the items that they list in there, I hear a superpower. So then that would be the way that I would introduce TS. Okay. When I am in CBIT, when I'm working with a patient in CBIT, sometimes I'll even invite their sibling to the CBIT session 1. CBIT session 1 is often when we focus on the science of the brain. And so I want as many family members as possible at that module, because that's a learning experience for everybody, right? I think a lot of my younger patients with TS are afraid to tell their siblings because they think that might make a target for bullying or, sibling rivalry or frustration. And so I would set a precedent very clear with that sib, whether they're younger or older, that this is not something that we tease or make fun about, or say nasty things about. We're trying to support, or trying to build resilience. We're trying to, support them as a family, and it's important that the family should know. Okay, good. Someone wrote, video games help me too. So yes, I wouldn't share this with a lot of my little kiddo patients, but if you are playing a game where you are using your frontal lobe and you're remaining in a neutral state, video games might work, right? For my younger kiddos though, slipping right into that excitement dopamine bucket is very tempting. So we would maybe not use video games when we're practicing relaxation strategies, but it's still okay to play video games. I would not be anyone's favorite doctor if I told them not to play video games. Okay. Sorry to ask another question. This is Rachel, upside down. Could you please tell me if my son's issues will be lessened after puberty? Okay, good question. So as you guys know, puberty is a magical time for many things. And there have been some studies that have demonstrated that after puberty, we have a difference in tics, right? Unfortunately, a lot of that data shows that some tics improve after puberty, some tics stay the same, and some tics might get worse. And so that really is the definition of a chronic diagnosis. So sometimes families are really hoping for puberty that things might change, and they might change for positive, but I would still be able to provide support even pre-puberty so that we're ready for the ride, whatever that ride may be. Okay. Heather writes, what strategies are useful for Traetic type OCD behaviors? For example, needing to touch something in a particular way, but not because they feel like something bad will happen if they don't. Again, there is overlap between OCD and tics. right? And when you look at like the DSM, right? So the DSM is the Diagnostic Manual for Mental Health. The difference between OCD and tics is that obsessive thought, right? That thought that if I don't engage in this compulsive behavior, maybe something will happen, or a magical thought associated, right? However, that's sometimes hard to identify. So that's why CBIT and CBT have a lot of the same core components. And so what I would say, Heather, would be probably lean heavy on a CBT provider or a CBIT provider that can start working on some of that compulsive behavior, because a lot of that compulsive behavior can be addressed with the same CBIT strategies that you've been using. So again, this might be a really nice time to go back to the CBIT provider and just do a couple booster sessions on compulsive behaviors, even with the absence of the thought. Okay. Rhonda wrote, when is it developmentally appropriate to start CBT? Good question. So obviously CBT relies very heavy on attention, and it's a thought-based intervention. So those are two key pieces when you're thinking about if your child's going to be successful in CBT. Oftentimes kids start CBT young, so they might start 5, 6, 7, but maybe that provider is really working on behavioral intervention strategies for parents, and they're going to fold that child into the intervention as they get a little bit older. So I think sometimes parents want to wait until maybe their child's 8, 9, 10 to start CBT intervention. But what I would recommend is, if you can, connect with a therapist, build rapport, and then maybe that therapist is going to work with parents first and then work with your child as they get older, right? It's always good to start with early intervention regardless of what you're trying to tackle. Okay, there's great programs that are built on CBT. So there's something called Triple P. So Triple P stands for the Positive Parenting Program. And Triple P is a program for parents where a therapist would work almost exclusively with the parents on doing positive behavioral support intervention for kids that are 2, 3, 4, 5, and 6. And so that might be maybe your first thought, especially if you have a younger child with rage attack, right? So if I had a 5-year-old with rage attack, what I would probably do is start that family in Triple P, learn some really good behavior strategies, and then fold into CBT as they got a little bit older. Okay, Rita writes, what is a possible reason that an adult with TS takes blame on others for their life choices, maybe unrelated to TS? Great question. Okay. This is important for you to hear, but I actually think that goes back to our discussion of superpowers, right? People with TS are intelligent, sensitive, and perceptive. And so if you're taking the blame and weight of others, there's 3 superpowers I hear in that, right? A lot of the patients that I work with care for others in a way that's incredible, that I don't know if the rest of us may experience, right? They really feel the pain and stress of others. And while that is a superpower, and while they go on to do incredible things professionally, having the weight of the world on your shoulders is an incredible task and an incredible burden, you know? And so I would say, yes, potentially that is related to TS. And yes, that is a superpower, but it can get too heavy, right? Especially if you're that person in a relationship or in your friends that are just taking on the weight of everybody, right? There's always that friend that's like the counselor in the friend group. And so what I would want to make sure for you is that you have a place to offload that weight, you know? So that's what a good therapist would do, right? A good therapist would kind of let you unload that weight that you're carrying with other people, okay? When I work with adults with TS, a lot of times they bring in the cares of other people. So even though this hour is supposed to be about them and their needs, we're spending a whole lot of time talking about the stress that their mom is having, or their best friend's breakup with their boyfriend, right? We're not spending time on them because they just care so cellularly, right? Sometimes in my own practice, what I will do is I will carry a pocket of paper clips. And every single time that adult talks about another person or the weight and stress of another person, I'll link a paper clip in my pocket. So they might not even see I'm doing it. And then at the end of the therapy session, I will show them the necklace just to show them how much of their time is spent on caring for others. And that's incredible, but we got to keep some gas in the tank for ourselves. Okay. Sometimes I use the analogy of a bank account, right? We got to keep our bank account in the black. if we just let people withdraw and withdraw and withdraw, we're going to go into the negative, right? So we got to have those people in our life that are putting deposits in so our bank account can stay even. And so that's something I would challenge and ask you is make sure that you have people in your life that are putting deposits in your bank account. Okay. Right. Carrie says, would you speak to how to manage family members who don't understand TS and instead believe it is a behavioral issue? What if you cannot get through to these people? Carrie, outstanding question, right? Again, I would really use that iceberg, right? I think it's very common for people not to understand what TS is, right? Because so historically we have thought TS was, oh, that's just screaming swear words. That's what it is, right? We're not realizing that there's so much more, and that patients that have coprolalia represent a pretty small portion of TS as a community, right? And this is often the earthly challenge for people that have chronic health diagnoses, regardless of if it's TS or asthma or epilepsy, right? They unfortunately often have to be that person that's correcting and changing the narrative, right? And saying, you think you know what TS is, but let me teach you what it really is, right? And so there might be people that never understand. And maybe I would comment like on Rita and ask you, are they making a lot of withdrawals in your bank account? Are these people that should be around in your life, right? I would rely on the visual of the iceberg to talk about all of the pieces that are connected to TS. And it isn't just the tics, right? I think a lot of people think the tics are behavioral, right? This is just something that people can control. They're just doing this for attention. They're just doing this to escape tasks. I've even heard teachers talk about that. And that's where you, as an incredible family member or parent and your child, that's where you guys have to advocate, right? And again, great therapists practice teaching kids and parents how to advocate. How do we share our story with others who might not understand? Right? And how do we realize when someone's asking questions versus when somebody's bullying, right? These are the challenging pieces about living with a chronic diagnosis, right? If it is a school, I think that's something that happens often. What I will do is I will have a meeting with my family and the school, and I will help kind of teach and recorrect that narrative about what TS is. We're so lucky in the TA community to have Wendy Wegman, who would also do that on your behalf. So Wendy would be a really good person, Carrie, maybe to reach out to, because she has tons of resources in her pocket that she could probably shoot to you, things that I'm not even thinking of. It's hard. That's a really good question. Okay, Mandy says, hi, could I ask, do you think medication for anger is worth having? My 13-year-old has extreme rage and throws things violently out of control and has mood swings that are violent and extreme. Would apropizole or sertraline help his erratic mood? Thank you so much. He has TS, ODD, and ADHD. So again, I would probably punt that question to a medical provider. Know that there is no perfect medication for TS. When I work with patients, I say, why would we want perfect medication? Because we don't want to impact our superpowers, right? A lot of patients that are acting out in rage and anger, that often can be anxiety, right? Because they're going into that fight, flight, or freeze response, and the response their body is choosing is fight. And so it wouldn't be uncommon for me to think about a provider maybe using anxiety medication. I would say, given his profile, what I would recommend is seeking the expertise of a psychiatrist, right? Because it sounds like there's some combined pieces in here that a good psychiatrist would look at your son holistically. I wouldn't just want to treat all the little symptoms. I would want to think about, again, what's driving the bus, use that in my darts in the dark game, and then start low and slow. That's where I would start. Again, this would be something maybe to talk to your primary care provider or your neurologist to see if they're comfortable with, but just because of the combined nature of what you're describing, probably psychiatry would be the best fit. Arlene writes, it's so difficult to parent a 9-year-old boy with rage and outbursts and his attacks on his sister who is 11. She hits back and it's emotionally exhausting. I totally can understand that. I think, siblings often need support in understanding the iceberg, right? And understanding all of the pieces of TS. So I can get how that's pretty stressful. Okay. Okay, Rhonda writes, my grandson takes medication that helps him with his rage attacks, but it's really like throwing darts in the dark. Okay. Okay. So Mandy writes, our specialists in mental health refuse. They say just therapy and not medication. Okay. So yeah, it sounds like a lot of you guys are, again, seeking support from each other, which totally fits into how we started this conversation about resilience. You know, I can speak from my expertise, but I know there is no better expertise than being a parent of a child with TS or having TS yourself. You guys are truly incredible experts with so many superpowers. So I think that's why it's so special that we have this community here, because you can probably learn the best from each other. Colette writes, I'm just joining. My 15-year-old son has loud vocal tics, but does not do them in school. How is that possible for him to suppress? Are they not true tics if he can suppress them? Colette, great question. This really focuses on, we talked about this a little bit earlier, but probably because your son is awesomely concentrating and focusing and using his frontal lobe, just like our friend from Ecuador was describing. So using his frontal lobe in intellectual efforts. And so because of that, he is not stressed, he is not excited, and he is not bored, so his tics are down. Okay. Paulette, this is the perfect question because this is sometimes what contributes to that fallacy that tics are behavioral, right? He is able to focus, right? And so when he's focused, his tics are kind of in the back seat, right? If he's experiencing boredom or stress, those tics might come up to the front seat. So maybe when he's home, you're seeing a lot more tics. Maybe he's suppressing them during the day, you know, because that's his safe place. But in school, he doesn't. And that's a really common pattern. Yep. So that does not mean that they're suppressible. That does not mean that they're behavior. That kind of just links to the science. And then just for our last question, Carrie writes, would you also speak to the importance of acceptance from a parental perspective rather than chasing magic cures? What a great question to end on, Carrie. So again, so many families wait months to see me, and I know that it is so hard to hear that tics are chronic, right? Because we're looking for that magic bullet, right? We're looking for that magic medication or that magic treatment that's going to make tics go away. And so I really emphasize the chronic nature of TS, right? And that's why we always lean heavy on the superpowers, because those are incredible attributes that you cannot train into somebody. Those are born into people. And so that we don't want to change that, right? And so when I work with kids, we work on accepting those awesome superpowers, but accepting the hard tic days, because that's a side effect, right? That's a side effect. And so focusing and describing tics as chronic sets your family and your child up for success, because the chasing a magic cure and a magic bullet, that ends, right? It ends because we know some days tics are good and some days tics are bad. And that doesn't mean we failed as a parent. That doesn't mean as we failed as somebody with TS. That's just the way life was, right? And if controlling tics meant we got to remove all of the exciting parts of life, but we wouldn't want that, right? So being a good advocate, creating a tribe, you know, establishing resilience as something with around us instead of something within us, that's how I define success in somebody with TS, right? Advocating for themselves, correcting the narrative, standing up for themselves or other kids that are going through chronic health diagnoses. That's what I'm talking about. That's what success is, not a magic medication or a magic intervention. Last thing I want to say with mental health treatment, I say this a lot to my patients, that when you start treatment, whether that's medication or intervention, it's not like one day you wake up and your problems are gone. It's that what someday you turn right when you always used to turn left, right? And then what happens is if I keep turning right when I used to turn left, I zoom out and I have a beautiful map of a place that I didn't know I could get to. That's what mental health success is hitting those intersections and turning a different way that we used to not turn. Okay, so thank you guys so much. If there's anything that you need, please feel free to reach out to the TA Association. If I missed your question today, I'm happy to answer it in an email, okay? Keep fighting the good fight. I'm so proud of being part of this community. You guys truly are superstars. See ya.